Welcome to another lecture on respiratory muscles, part 2. In this video, we will be covering actions of respiratory muscles and respiratory muscle interaction. In first section, we will analyze actions of individual respiratory muscles, beginning with the diaphragm, then moving on to intercostal muscles, focusing on their functional and mechanical role in breathing. Core principle on action of respiratory muscles and ventilation. Ventilation is driven by pressure gradients, especially transdiaphragmatic pressure, and requires coordinated interaction between diaphragm and the ribcage. Without this coordination, effective breathing cannot occur. First, the diaphragm. Diaphragm is the most important inspiratory muscle, and it is innervated by phrenic nerve arising from C3 to C5. It consists of costal and crural parts which have different anatomical origins but function together during respiration. It has three mechanisms of actions. First mechanism, diaphragm contraction causes descent, which increases craniocaudal dimension of thorax, and this descent is tightly coupled with outward movement of abdominal wall. Second, diaphragmatic contraction increases abdominal pressure. This pressure is transmitted through zone of apposition, the area where diaphragm is opposed to ribcage, resulting in expansion of lower ribcage. Zone of apposition constitutes of about 25 to 30% of inner ribcage surface at functional residual capacity and plays a crucial role in transmitting abdominal pressure to expand ribcage. Third mechanism of action. Diaphragmatic fibers insert into lower ribcage. Their contraction pulls rib upward and outward, producing expansion of lower ribcage. This is known as insertional component. Diaphragm in isolation and coordinated breathing. When diaphragm acts in isolation, such as in quadriplegic patients, it can produce an expiratory effect on upper ribcage during inspiration. This shows as diaphragm alone cannot generate normal breathing mechanics. In normal individual, quiet breathing is not achieved by diaphragm alone, but by coordinated muscle activity between diaphragm, ribcage muscles and abdominal muscles. Next, intercostal muscles. Intercostal muscles occupy space between ribs and are arranged in layers. Outer layer forms external intercostal muscles, while inner layer forms internal intercostal muscles. Fiber orientation and function roles of intercostal muscles. External intercostal muscles run obliquely downward and forward, whereas internal intercostal muscle runs downward and backward. This difference in orientation determines their function roles. Based on fiber orientation and rib mechanics, external intercostal muscles are primarily inspiratory, while internal intercostal muscles are primarily expiratory muscles. Parasternal intercostalis. Parasternal portion of intercostal muscle is consistently active during quiet breathing and represents most important inspiratory component of intercostal muscles. Mechanical advantage of intercostal muscles. Mechanical advantage of intercostal muscles varies across ribcage. External intercostal muscles have greater inspiratory advantage in upper and dorsal regions, while internal intercostal muscles have greater expiratory advantage in lower interspaces. Functional organization. Because of this topographic distribution, The pattern of neural activation matches mechanical advantage, resulting in inspiratory function of external and parasternal intercostalis and expiratory function of internal intercostals. Levator costae. Levator costae muscles elevate ribs and contribute to inspiration, although their functional role is relatively small compared to intercostal muscles. The scalenes. The scalenes originate from cervical vertebra and insert into first and second ribs. Their contraction elevates upper ribs, producing a pump handle movement. Importantly, they are consistently active even during quiet breathing and contribute significantly to upper ribcage expansion. Clinical relevance. In spinal cord injuries below C4 to C8, scalene function is often preserved, making them important contributors to upper ribcage movement and also ventilation in these patients. Next, sternocleidomastoid. Sternocleidomastoid runs from mastoid process to sternum and clavicle. Although capable of generating inspiratory pressures similar to scalenes, it remains electrically silent during quiet breathing. Recruitment of sternocleidomastoid. When does it activate? Sternocleidomastoid is recruited when ventilatory demand increases, such as respiratory distress or diaphragmatic dysfunction, making it a marker of increased work of breathing. Shoulder girdle muscles and other neck muscles. Several shoulder girdle and neck muscles contribute to inspiration under specific conditions. These muscles act by expanding the ribcage when it is fixed, particularly during increased respiratory effort. These include trapezius, latissimus dorsi, pectoralis major and minor, serratus anterior. COPD mechanics. In COPD, patients often adopt a lean forward position with arm fixed. This stabilizes the ribcage and allows accessory muscle to effectively contribute to inspiration. Functional limitation. Although these muscles assist in breathing, their use is inefficient and energy consuming. This limits patients' ability to perform other activities and contribute to increased dyspnea. Clavicular head of pectoralis major. Clavicular head of pectoralis major can act as a expiratory muscles when arms are fixed. Its contraction pulls ribs downward, increasing pleural pressure and facilitating expiration. Triangularis sternae. Triangularis sternae anatomy and function. Triangularis sternae lies on the inner surface of thorax and acts to depress the ribs relative to sternum, thereby producing expiration. It is recruited particularly during expiration below functional residual capacity. Main features of triangularis sternae is that the muscle is electrically silent during quiet breathing but is recruited during expiration. It has lower recruitment threshold than most expiratory muscles and acts in coordination with abdominal muscles. Abdominal muscles. Abdominal muscles consist of 4 layers: rectus abdominis, external oblique, internal oblique, and transversus abdominis, forming a functional unit for expiratory activity. Action of abdominal muscles. These muscles act by pulling abdomen inward, increasing intra-abdominal pressure and pushing diaphragm upward, thereby facilitating expiration. Other actions and recruitment of abdominal muscles. Although primarily expiratory, abdominal muscle contraction can sometimes assist ribcage expansion through increased abdominal pressure, demonstrating complex interaction. Abdominal muscles are usually silent during quiet breathing but show tonic activity in upright position. They are actively recruited during exercise, hyperventilation, and forced expiration. Recruitment pattern. In quiet breathing, diaphragm, parasternal, and scalene muscles are activated. During distress, sternocleidomastoid and accessory muscles, and in forced expiration, the abdominal muscles. Respiratory muscle recruitment hence depend on demand. Increased use of accessory muscle indicates increased work of breathing. Transversus abdominis. The transversus abdominis has a lowest recruitment threshold among abdominal muscles and plays a key role in early activation and stabilization. Next section, respiratory muscle interaction. Respiratory muscle interaction is best understood using conomet relationship, which combines ribcage and abdominal motion. The relaxation line represents passive chest wall behavior when muscles are not active. Conomet diagram represents interaction between ribcage and abdomen during breathing. The x-axis shows abdominal cross-sectional area, while y-axis shows ribcage cross-sectional area. Each loop represents a complete breathing cycle starting from functional residual capacity. In normal breathing, the loop is elliptical, indicating coordinated expansion of both ribcage and abdomen during inspiration, followed by passive return during expiration. In diaphragm paralysis, the pattern changes significantly with reduced abdominal expansion and paradoxical ribcage movement, reflecting loss of diaphragmatic contribution. In quadriplegia, the loops become altered due to loss of intercostal muscle function, leading to abnormal chest wall mechanics. At high-end expiratory lung volumes, breathing occurs near total lung capacity and loops shift along the relaxation line, indicating reduced compliance and increased mechanical load. The dashed relaxation line represents passive expiration when respiratory muscles are relaxed, highlighting elastic recoil properties of respiratory system. Normal versus postural effect on quiet breathing pattern. In upright position, ribcage and abdominal expansion occurs proportionally along relaxation line. In supine position, abdominal movement becomes dominant due to altered pressure mechanics and diaphragm position. What happens when diaphragm acts alone? Is diaphragm alone enough? When diaphragm acts alone, such as in quadriplegia, it produces abdominal expansion but fails to expand ribcage effectively, sometimes causing inward movement of upper ribcage known as paradoxical motion. Importance of coordination. Normal breathing requires coordinated activity. The diaphragm contributes about 60 to 70% of tidal volume, while intercostal and scalenes provide remaining contribution and stabilize ribcage. Importance of interaction of these muscles. Key takeaway is that posture and muscle interaction determine breathing efficiency. Loss of ribcage function leads to abnormal mechanics such as in quadriplegia and neuromuscular disorders. In summary, diaphragm works with ribcage, intercostals are region specific, Abdominal muscles are active regulators, and breathing is a coordinated mechanical process involving multiple muscle groups. Understanding this integration is essential for both exams as well as clinical practice.